Bill, what if I told you that losing teeth isn't just losing teeth, but actually reduces the longevity of your life?
I tell you there's a hidden cost to tooth extraction, and that's what we're going to explore today on today's episode of For the Love of Endo. I'm Bill Nudera.
I'm Dr. Brett Gilbert.
And we're here to elevate endodontics one conversation at a time.
And so For the Love of Endo is about saving teeth. And, we think about it in terms of aesthetics, phonetics, eating, all of these beautiful things. What we don't necessarily think about is that the longevity, how long we live, has the studies show is actually dependent on how many teeth you have.
And it's pretty impactful too when you look at some of the research. And they say the mouth is the gateway to the body. What we put in, fuels our body, and so we can look at the mouth and we can really have a good sense right away during those initial exams how healthy is this person just from their oral hygiene and frankly how many teeth they're already missing.
Yep.
So what are those stats? What do those stats
let's
say?
look at it. So basically there is a linear relationship. Basically the longevity of your life is dependent upon how many teeth you retain through the course of your life, especially as you get older. So for instance, losing 10 teeth, you have a 15% greater mortality risk. Losing 20 teeth, you have a 33% increased risk.
That's significant.
I mean, that's a third of what your long-term expectancy can be. And if you lose all of your teeth, 57% increased mortality compared to someone who does have their teeth.
So why do we think this is? Is it because of the lack of nutrition, or is it because somebody who typically historically loses more than one or starts losing a significant amount of their teeth has also other health concerns, or is it the teeth that lead to those other health concerns? I mean, where is this the balance here?
Yeah, well, I'm happy to see that the statistics actually show you're getting up to the number 10 lost teeth before you're starting to show some of these statistics. So what does that mean? It means either someone maybe didn't have access to good care, right? Maybe didn't have good oral hygiene or good habits. We recognize, look at what causes tooth loss now, right? We can look at severe caries risk from just having a lack of education, from having a lack of, dare I say, fluoride in your water, right? Especially as a youngster.
Diet. Soda, that canned sugar that we keep bathing our teeth in. So I think we know the cause of tooth loss here.
And we should include drug use as well as a significant factor, which would also explain some of these things. So I think there's some connections to be made here, but the overall theme is that, yes, there is a very significant hidden cost to tooth extraction.
What does this mean? Does this mean we should make more attempts to try to preserve those natural teeth if it's going to impact life so much? That makes sense to me.
It does. I agree. And I think that's what we're all about anyway. That's what Endo is all about. And I think we're seeing an even bigger, higher purpose calling to this idea of the life-changing power of saving teeth.
So the question we have to now pose is, certainly not every single tooth that walks into our office is treatable or savable. So now we have to develop some criteria of when do we have that prognosis, that predictable prognosis that's going to allow us to save that natural tooth, to prevent some of these statistics that you had just mentioned. Because there is a fine line. Even though we want to save teeth, not every single tooth is a candidate for treatment.
Yeah, that's true. And
so where do we draw that line, and how much do we use this information to promote trying to save the tooth, even in these heroic situations?
Yeah, so I think there's a lot of changes that have come up in terms of when you would save a tooth that maybe you're doubting has a good prognosis. One that I come to think of is medications, right? Like bisphosphonate treatment. So we are already of the mindset of sometimes retaining the natural tooth, even if it's not ideal, even if it's not going to be perfect, even if you can't give a great 5 to 10 year long-term outlook, that there's still a benefit to the patient. So with that, I think we've become very creative in creating strategies and clinical procedures to save compromised teeth. I know I've seen you do it. I know I do it. So I think what the purpose of this episode is to say, hey, there's maybe even a bigger reason why we would step into a tooth with a guarded prognosis and present it to the patient as an opportunity to try to save it.
Yeah, and I think that's what we're going to be focusing on today too, because when When the conditions are right, a small carious lesion or the tooth's got a lot of good structural support and the conditions are extremely favorable, it's a no-brainer. We try to retain the natural tooth. I think every single dentist that graduates dental school, takes this Hippocratic oath of do no harm. And part of this is the preservation of the natural dentition. We work with a lot of oral surgeons that will send us cases because I'm not taking this tooth out and try to save it first here. So it's important that, we're these pillars in our community that promote saving the natural tooth. But I think the conversation here of the hidden costs of tooth extraction are, how much are we going to be heroic to try to save that natural tooth? And to your point, we're looking at some medically compromised patients, and then some patients are just willing to do every single thing they can to try to keep that tooth in their mouth. I just saw a patient recently. She is going through cancer treatment. She's been on chemotherapy. She's in her early 70s, and during I got referred to this patient, a lot of caries on the maxillary arch. The lower teeth were just fine, but every single carious lesion was interproximal, sub-G, and in line with the alveolar crest. And there have been some heroic cases that we can do these treatments on. But part of the consultation when I was talking to her is trying to really understand not just what kind of chemotherapy she's been through, because a lot of the chemotherapies for cancer include some sort of bisphosphonate medications. And we've got to understand that that's going to have an impact on tooth extraction itself. And so we got to kind of weigh the risks and benefits of making the attempt to save versus extraction. But in this case, she was going to be on chemotherapy for the rest of her life. And even though I'm all for doing these heroic procedures and rebuilding margins and trying to tackle these cases, the problem is if we do cases on patients like that, it's only a matter of time before the chemo starts breaking down even those restorations. So now we have to really reflect, is that the best idea? So I think we're always 100% focused on saving that natural dentition, but there's a lot of variables that go into this here too. So how far do we go to try to do this?
Yeah, and I think you're creating a scenario here where we're talking about someone who already has a very severe illness. So I think that plays in then to, we want to help the patient. We don't want to hurt their overall well-being. But what about that patient that fractures a tooth, right? And then is asking you, well, it's obvious that I can't save this tooth, but should I replace it? Right? And replacement could look like some different prosthetic options. It could look like an implant. We also have to remember that when you take a tooth out, you lose a tremendous amount of bone. And I've always considered that as a way to describe to patient, listen, sometimes in these more medically compromised patients, even sectioning a tooth coronally and keeping the root in and burying it is great because it's preserving the bone. It's now preventing a traumatic type of surgical extraction. So I think there's just a lot of nuances to it. But the thing that I didn't know real well was these longer term perspective studies that truly show that there is this direct relationship between the number of teeth that you retain throughout your life, especially as you get older, and how long you will live. And the fact is that's important to know as a dentist when discussing with the patient their options.
So I'm sure you've seen patients who have come to you for treatments and maybe the tooth wasn't restorable. Use recommended extraction, they get their implant, but then yet another tooth develops a problem. They come back and, in the consultation, well, we can try to save this one. This one may be a candidate for a root canal treatment, or you can consider extraction and get another implant. And I'll have the patient say, I don't want to go through that again. I don't want to do the implant again. I mean, first of all, implants are great. We place them in our practice, but we have a focus on saving the natural tooth. But patients also, once they go through experiences and realize that the journey of getting an implant is not just taking a tooth out and put an implant in, and I think that's the perception that they have, is they're going to make maybe a more of an attempt to try to preserve their natural tooth to avoid that. But that also brings up another issue too, compounding costs, right? So in favorable cases, nothing's 100%, right? Statistically, Endo does have a favorable success rate. Most of what we do works. That's what we keep coming back for. But sometimes it doesn't work. And one of the costs, though, of making the attempt to try to save these heroic cases is not only is loss of time, loss of money, loss of the tooth, but now it's compounding costs of them having to now go through that tooth replacement option. So these become very delicate conversations because nobody enters into any of these treatments with the expectations of things not working. When they enter into my treatment, when they enter into your treatment, when they enter into your treatment, they are expecting that it's going to work. So we just have to make sure that they understand that, there's always some level of risks that come along with making the attempt to save it. But just based on these statistics alone that we're bringing up today, it may be worth the risk if it's going to extend our longevity. Don't you agree?
I agree. And that's where the hidden cost is. And I think what you just said is important is allowing a patient to understand that's communication. And we talk a lot about that, but it's about how you describe it. And to me, I honestly, this is newer evidence for me. This will work its way into my conversation, which is to say, and I have an implant. Had it for about 8 or 9 years.
And how's it working for you?
It's been fine. It was not an easy process.
Can I ask how you lost the tooth?
Yeah, so I had a big amalgam in it, and I was out one night very, very late with the boys, and we went to this Italian place at like 2 a.m, and I bit down on a piece of shrimp, and the tooth broke in half. I wound up getting endo. I got a post-core and a crown. The crown and the core kept lifting up, and finally it was decided it was done. And I went through, I had a bone extraction, a bone graft. I had the implant. I waited. I, got the crown. I got and it was a big deal.
How long? So let me ask a couple follow-up questions with that. Root canal is done at at 0.
Okay.
Okay. How long after you had the root canal procedure done are you now removing that tooth, grafting, and going to the implant?
Probably about 1.5 years.
Year and a half. So why do you think it didn't work as long?
I don't know. I think probably it was slightly non-restorable, but because I was a dentist and an endodontist and it was a colleague that was working on me, that we felt like we would go for it.
So it was more of a heroic process.
Yeah, it was on the gray area and it just didn't work out great.
So now from that perspective, now that you've been experiencing that yourself, does that influence the conversation you have with your patients when you see another tooth with that similar condition?
Yeah, it does. I mean, I basically just am able to explain that I've had an implant. I always say, there's going to be a moment where you're going to be tempted after you've had the bone graft, all the gum tissue is healed, and you're going to be tempted to say, I'll just leave it.
I don't miss it.
I don't miss it, right? But the reality is that for function, for health, for positioning of the other teeth, for stability, I do think it's important to replace a missing tooth, and all the more now seeing these statistics. So ultimately, it's not as easy, which is why the conversation about endo and retreatment and surgery is important, because, the patient needs to know that will be done right now. You'll be healed up in a few weeks. And then if it wins and you win big.
You do.
So that's why I always try to tell patients, both sides of the coin. And maybe it was a good experience for me that I had to have an implant, because I was able to go through, I've been through endo, I've been through post-core crown, I've been through the implant. So, but ultimately I do think that there is a hidden cost that maybe many of us are not aware of. And the reality is that is a very important topic of conversation to have with a patient as they're trying to make a decision.
Well, one of the most common questions that I get asked is, what would you do if it was your tooth? What would you do if it was somebody in your family? And, my answer to that question, and we're not talking about the obvious, the most predictable cases here. We're talking about those borderline cases, those cases where there's a large carious lesion, you have to do some distal marginal elevation, and maybe you have to end your crown margin on restorative material. I know it's not ideal, but I've seen these things work for several years.
Absolutely.
Can we expect a lifetime out of that tooth? Maybe not. But our definition of success is very different than what a patient's definition of success is. One of these aha moments that I had, this was, maybe about 4 or 5 years after I had opened my practice after dental school. A patient was referred to me for tooth number 3, diagnosed with symptomatic irreversible pulpitis and symptomatic apical periodontitis, had a full coverage restoration on the tooth. I went through my entire consultation, and I have pretty streamlined consultation. It's very automatic for me at this point in time, going over risks, options, benefits, all that good stuff. And he says, and I gave this patient, I go, you have a really biologically favorable starting position, meaning no lesion, bone is healthy, tooth is vital, all that stuff the literature tells us should work, right? So we do the treatment, found 4 canals. I was really thrilled with this. We always celebrate when we find that 4th canal. We see it on the X-ray. It looks so beautiful, right?
It's a gift.
So I get it done. I'm like, listen, John, this case turned out fantastic. I'm showing him all the stuff that we did. He shakes my hand, he leaves, we're all great. And then 2 years goes by, he develops a lesion on this mesobuccal root. And I'm thinking, gosh, why is that the case? Because it's odd with our aseptic protocols that we use and a vital case. Now, all of a sudden, now we've developed a lesion. That implies that maybe there's a breach in my aseptic field. Who knows? Maybe there was some leakage going on. We didn't remove the crown. We went through the crown. There's a lot of variables here. So, I talked to John and he says, it's starting to hurt me again. I go, well, here are your options. We could do a surgery. We can try to retreatment. I didn't really push towards the retreatment, Fred, because I did it.
Especially in that anatomy.
First time. And one thing about endo is if you did the treatment, you're going to take it to surgery. Yeah. But if somebody else did the treatment, you're going to retreat first. Don't ask me why that is. That's just kind of how it is. Am I right?
Sometimes, yes, I agree. Yes.
So he says, okay, all right, I'm going to take this to surgery. And I'm still motivated to save my tooth. So I'm like, okay, I do the surgery, and it's a beautiful surgery. I get the isthmus, and I get my final image, and it looks great. I'm like, this is an ideal surgery. John, this is going to work for you. Because the statistics say endo, when it's treated by the same person, the surgery's done, the success rate should be elevated. And it was fine for another year and a half. And he comes back to me, the lesion got bigger.
Oh, gosh.
And I'm thinking, oh my gosh, I'm telling this patient that we've got this high success rate with these procedures we're going to do. And now I've exhausted all my options, right? We've treated, we've surgerized. And I'm saying, John, there's nothing more I can do. And he was okay. And he said, okay, we're going to have to get the tooth removed. So I sent him to a buddy of mine, oral surgeon, took the tooth out. And then he comes back to me another 2 years later, implant in place, and with tooth number 2, with the same exact symptoms, the same exact diagnosis, symptomatic irreversible pulpitis. And I said to him, I looked him in the eye, I go, John, here are the options. We can make an attempt to try to save this tooth with a root canal, or you can just go right to your implant. And I said this. I go, I understand if you don't want to do the endo because of what happened to us last time. And if you want to go right to the implant. And you know what? He looks at me and says, Dr. Nudera, what do you mean not do the endo? It worked for me last time and the surgery worked for me. I was pain-free for a good few years. Let's do the endo. All right. So my definition of success was, I got to have this tooth for a lifetime.
Right.
John's definition of success was, hey, you got me out of pain twice. And I got 3 to 4 years on this tooth before I had to get the implant. I want to keep my tooth. So for him, it was a no-brainer to try to say that.
That's powerful.
And then bam, that light bulb went off on my head and said, wow, I'm looking at success from a very pure and rigid statement here, where that's how we're trained. But from a patient's perspective, in these heroic cases, and I'm kind of looping back to that, is sometimes a year or two for that patient until they can get their mind or their head wrapped around removing a tooth and going to implant is a success for them. So I look at success very differently now, 20 years out than I did when I first saw that patient. So that was a big deal to me. So although I was promoting and tooth survival and saving teeth, I actually was trying to give John an out.
Well,
and he didn't take it.
Understand, because you were holding something personally for the fact that you couldn't deliver for him. But
I felt responsible.
But I always say, is part of this, first and foremost, so what's important as a dentist is not to take the worst case scenario and have it then extrapolate onto others. Because I always tell patients one thing. I always say, listen, this isn't like a perfect situation. It's definitely more questionable, but we'll only know what your body is capable of in terms of healing by giving it a chance.
You bet.
And you never judge like what a patient's going to decide, yes, no, or otherwise. You just have to sort of give them all the facts and pass no judgment, but answer questions in a very complete way. And so for me, it's like, looking at all these different scenarios where the tooth might be questionable and saying to the patient, John, you had decay that got under your crown, which has caused the root canal we did to unfortunately unwind itself. Now we can fix that, but if we don't also address the source of your decay, you're going to wind up in the back. So using these moments as a chance to try to get a shift in someone's diet, their oral hygiene technique, all these different things. So yes, we are endodontists and we're in this small area, but what we do really does extrapolate out to the entire oral health picture of a patient and often the treatment plan as well. So let's take a different scenario, okay? Now we have an esteemed colleague, let's call it a prosthodontist, who is developing a rehab case for a patient. And in all genuine honesty, the one tooth in question is going to be the pivot point from having the plan look like this or having a completely different plan. So now what do? Right? Do you take no chances at all? Do you look at only the most predictable possible outcomes? Do you just succumb and say, just take it out and do an implant? These are the types of treatment planning scenarios that endodontists need to be a greater part of. Because what I'm afraid of is that we're extracting teeth out because of not really understanding what's possible.
And the fear of what could happen if we try to keep it.
And the hidden cost of that, which is
help,
is longevity of your life. So I think it's a really great topic. I think ultimately the value of the natural tooth is so important, but there are three things that really doom a tooth, right? The natural structural decline from a bacterial infection or cellular with resorption nowadays. That's number one. Number two, stress and strain, bad occlusion, power function, etc. And then the part that we can't really control as much was the quicksand of periodontal disease. So how much of these can you control? And what you can understand, we understand the connections of cardiovascular health to periodontal disease. One of the reasons a patient may find themselves edentulous by 10 or 15 or 20 teeth, reducing their life mortality risk by 15 to 33%, is periodontal disease.
Yeah.
So going back to why are you losing bone? And so this is where comprehensive dental treatment and team approach are important. This is where integrated care, I believe, is our future. So that instead of it being like, well, I'm going to send you to Dr. So-and-so, you make an appointment, they're going to do another scan. It's like, hey, Dr. So-and-so is actually right next door, and they're going to just come take a look, and we're going to collaborate on this. I think there's a lot of ways to go, but the hidden cost of extraction is deeper and greater, I think, than we thought.
So let's talk about the natural tooth versus the implant tooth. And you're a good resource. We're sitting right next to me.
Yeah.
You got one of each. Well, one implant and more.
Well, yeah, I got more teeth than implants.
So
for sure.
you have more. You've only lost one, not 10. So your longevity.
Right. Well, I have lost other teeth because I was a serial extraction ortho case. So I was 8 teeth down. So I'm probably 9 teeth down.
Does that mean your longevity? So
yeah.
Does it mean your longevity is decreased?
Well, let's look at.
And does serial extraction qualify for this?
And let's look at that, because the reason I had serial extraction, which they don't do anymore, is because I didn't have enough space. So I have all my teeth.
But no one's not going to accuse you of having a big mouth.
But the reality is that, I think we're talking about where there's spaces and they're shifting, because one of the things that, in our notes that we talked about is it's not just that tooth now is gone and all of that impact. How does it impact all the other teeth? How does it impact then your occlusion and how you bite and how you chew? And then does it compromise the next tooth? And all of these things compound on each other. But to answer your question, the proprioception, the positional situation, I mean, the periodontal ligament to me is a miracle.
I think so too. And that's what I was leading at, is you lose a lot of those biological signals that other teeth have that the implants don't.
Yep.
Not that I love implants. When the tooth can't be saved, we've done everything we can to fix it. There's no other option. Case in point right here. And I'll probably be a candidate for an implant or so in my lifetime too. It's just something that is available. I'm grateful for that option too. But you hear about space opening up between implants, because implants are fixed, they're rigid, but the teeth and the periodontal tissues are always remodeling themselves and moving around. There's always some sort of drift to the midline as we age, all these things, but implants are fixed. So that opens up potential other issues with them, with implants too.
Yep.
And again, nothing is without its risks.
Yeah, nothing's without its risks. And this is it's a conversation that we have to have with patients, and it takes a little bit of time, right? And sometimes I always say, if you're at the chair and there is a deeper conversation that's necessary, I have no problem saying, hey, Bill, listen, I think there's a little more nuance to this. What I'd love to do is I'd love to call you on the phone. I'm happy to hop on a Zoom with you. Let's talk this through in a little more detail. Right now, I'm in the middle of my clinical day. I have some other patients waiting. I'd like to be able to give you a little more of my attention. Would it be okay if I called you tonight, tomorrow, and have the conversation? Answer, because when we do it all at the chair, and in your mind, you're like, oh, I got it. Sally is ready. I know my assistant's giving me the side eye over here. I want to give Bill a little more time to describe all this, but you know what? I can only do what I can do. So do you want the tooth or not?
That's how it's approached sometimes. And it's a very cold way to approach these things. It takes the human component out
Yes,
of it.
it does.
Let me ask you a question. And this goes back to maybe a little bit of practice management too. How long do you allow yourself for a consultation? How long, like when your patient calls to your practice and say, I need a consultation with Dr. Gilbert, how long does that patient get scheduled for from the time they walk in?
Well, the way we look at it is we look at the patient's time in the office and the patient's time with me.
Okay, so define both of those.
So the patient will arrive probably a half hour before they're ready for the consultation. That allows all paperwork to be completed. It allows my assistant to do CBCT, which I do on every case I evaluate. It allows him to see it. It allows him to get the history. It allows him to get a periapical radiograph or bite wing or both. And then I come in. So I typically allow 10 to 15 minutes for me to evaluate the patient and have a discussion with this idea that I'm describing, which is it doesn't have to end there. I have no problem spending more time with a patient outside of my clinical hours because I don't like being crunched. So if I can be effective in the conversation at the chair, great. If not, I'll say, hey, Bill, listen, this is worthy of a little more of our time together. Let me give you a call. I'll have everything open at my desk. We can kind of go through it all. And I want to make sure you're comfortable with your decision. I think that's a good way to approach it.
When you're doing your consultations, are you double booking them with a treatment run next
Typically,
door?
yes.
Okay. So that's where we diverge just a little bit. I have static consultations worked into my schedule that do not overlap with my treatment. I like the idea, and I'm going to probably work that into my flow, is that there's a longer conversation to maybe not disrupt my clinic day, but I've honed my schedule, and maybe not a good business move because maybe I could see a next patient. But I'll sit and I'll spend at least, I'll spend more time with them than probably most, just to have conversations to make sure they understand that. But the times that I do kind of want to expand the conversation is when the referral slip comes in and 10 teeth are circled.
Yeah.
Right. So those we just, even if I have a static appointment and a dedicated appointment just for consults, there's just too much information to talk about in a short period of time. So in those situations, I say, well, let me just reach out to your restorative dentist. Let me get a little more information first, and then we'll talk over the phone. So I do like that approach too. But it gives a little bit more breathing room. And then maybe now the patient has a chance to think about their case. Well, there may be more to it than just I need a root canal, and they may be more willing to accept a deeper conversation.
Yeah, and if you're not comfortable saying, hey, basically you're saying, I don't have enough time dedicated.
That's what I'm saying.
But I love the spin, though, is to say, hey, listen, I have all the information that I needed with you in my chair. Let me go back to Dr. Jones. Let me pull them into the loop, and then let's have another conversation. That's another good segue. But I always think about, the time that we're in our offices with our teams, it's very limited and it's very valuable. And so to me, I don't want to get bogged down with all of these conversations that could happen at another time. That's how I shorten my consultation visits, but still live in the same thing. I use an example of when you take the final image and you're like, it looks okay. I'm busy. Everything's great. We'll see you next time, or we'll see you never, or whatever.
Because you don't want to deal with it then.
I have no problem calling the patient. End of the week, end of the day, I teach this to all the young doctors that I work with. Say, hey, John, I just want to let you know, at the end of the week, I review every case that I do. I want to make sure that my quality, and I took another look at yours, thought it was okay at the chair, but there's just this one little area I'd like to revise. Going back to the idea that I just always want to give you the best that I can possibly give you. Sure, is this being a little anal? Yes, but that fits the profile of this profession.
Many people would have just let that go.
That's
and
the
say,
point.
You know what?
That's
it's
the
fine.
point.
It's going to be fine. And I drill that to the residents when they show me a post-operative image and we look at that. And I just say, they showed up and they're waiting for me to talk. I don't talk. I ask them, you tell me what you think. And they start breaking down their case, every little thing. And if they come up short, there's a little void somewhere. And I say, this is your signature. This is your tooth. When you may be leaving this program in a year or two, but your name is always going to be affiliated with this chart. You need to make sure this case looks is treated as well as it possibly could, because this is your reputation. I let them come to that conclusion.
Yeah.
But I like how you approach
it. So I think as we wrap this up, the idea is that, especially with consultations, questionable teeth, questionable outcomes, don't limit the conversation to the chair where you feel pressured. but take it to the next level. And if that means maybe even charging some extended consultation fee, you could. I don't.
Yeah, I don't either.
You know, but I think it's more important to get it right. It's more important, especially now that we understand that the lack of teeth equals lower longevity. Look, we only get this one shot in these bodies, right? I think most people prefer to extend that for a lot of different reasons. And we don't often think as dentists that we have as much of an interplay with their overall health and long-term lifespan. But it's very clear that we do. And so taking that to account and making sure that these conversations happen in a way where your patient is fully educated, all their questions are answered, any personal anecdotes that you can throw in that they ask for, you're honest, and let them make the decision. And ultimately, we'll never know the outcome. Here, you had a perfectly sip-sap case that turned into a surgery, that turned into an extraction, versus something that looked terrible when you finished it and was still there.
So the human body is a very powerful thing. We always advocate, we always should be advocating to save that natural tooth whenever possible to avoid those other hidden costs.
Yeah. Bill, what I love about this topic is it's about patient communication. It's about understanding. It's about continuing to learn. New evidence pops up, and it might be in a conversation with a colleague. It might be in a journal. Actually, this bit of a pearl came to me from Dr. Brett Kessler, who I was interviewing, and he mentioned in the frame of the fluoride controversy, and I do this as for the controversy, that, yeah, we don't want to be losing teeth because the long-term outlook for lifespan is impacted. So I think we made the point. I think it's powerful, and I love how many facets of practice always come into these topics, right?
They do.
It's a beautiful thing.
So with that, I want to thank everybody for listening or watching, whatever platform you're viewing us on. And until the next time, we're going to elevate endodontics one conversation at a time.
See you inside the next episode.